The mission of the Tennessee Rural Partnership is to maximize access to primary care in Tennessee. In addition to helping communities recruit and retain primary care providers, we provide educational services on delivery models that might assist your community to address access to care. Tennessee currently has 6 PA training programs with more than 250 graduates per year. The expert faculty for this webinar, Best Practices for Physician Assistant Utilization in the Inpatient and Ambulatory, will provide information on the scope of practice and billing comparisons for PAs and other providers for your use in determining if a PA might help to address access to care in your community or clinical facility.
My name is Dr. Ken Harbert. I'm the Dean of the School of Physician Assistant Studies at South College, and today I'd like to welcome you to our webinar. Our objectives today: by the end of this webinar, participants will be able to successfully first identify as a whole the added value that a PA brings to both the inpatient and ambulatory care setting. Second, recognize the workforce issues when comparing the use of PAs versus other healthcare providers. Third, to define the reimbursement for PAs within both inpatient and ambulatory care settings. And finally, fourth, to define the solutions to the barriers and challenges for using the physician PA team within a healthcare system. And we will give examples of how it works best in both settings. Let me go ahead and introduce you to our speakers. Our first speaker, Mr. Michael Poe, is Vice President, Reimbursement and Professional Advocacy for the American Academy of Physician Assistants. In this capacity, he deals with healthcare policy, third-party payment concerns, Medicare, Medicaid, and healthcare reform. He is the author of the book, The Essential Guide to PA Reimbursement, and currently is an adjunct professor at George Washington University School of Medicine and Health Science in Washington, D.C. Our second speaker is Mr. William Fenderfrock, President and owner of Capital Associates. Prior to joining Capital Associates, he co-founded the National Association of Rural Health Clinics. In addition to rural health, he specializes in healthcare financing, health system reforms, and health workforce. He has worked in and with U.S. Congress for more than 35 years. He was the first federal lobbyist for the physician assistant profession and served more than 8 years as the Director of Federal Affairs for the American Academy of Physician Assistants.
Well, thank you, Ken. I appreciate that, and it's good to be with you this afternoon sharing some ideas and concepts about physician assistant utilization. And while much of my conversation will be about the financial and fiscal aspects of hiring a PA and working with a PA, I want to make sure that we have our priorities straight in terms of what this is really all about. Certainly, I realize that this is about making sure that there is improvement in patient care, patient satisfaction, and patient outcomes. While we talk a bit about the reimbursement issues, we realize that really it's about the efficiency for the healthcare team and how we improve physician productivity and avoid allegations of fraud and abuse. And once that's accomplished, then we start to worry about the issues of reimbursement and maximizing legitimate reimbursement for medical and surgical services that are being provided by PAs. I want to stop for a minute and talk about some common accounting terms. And for those of you who hoped and thought that you didn't have to worry about business when you became involved in medicine, that certainly isn't true these days. Anyone who deals with medicine realizes that if you don't get the business aspect correct, a lot of the other issues won't fall into place the way they should. So we're going to talk about return on investment. That is the measure of the gain or loss that's generated by an investment relative to the amount of money that's been invested. And in this case, we're talking about human capital as well. We also concern ourselves with the contribution margin, which is defined as revenue minus variable expenses. So when I talk to you about the contribution margin of a PA, I'm looking at both those concepts in terms of how PAs can be quality healthcare professionals, but also do great things to the bottom line of an organization. Both PAs and NPs are paid roughly 1/2 to 1/3 of the salary of their collaborating physician. That might be an oversimplification, and it does depend on the particular specialty that one is in. But the fact is, I want to make sure that we all realize that because of that differential in salary, what the PA earns in terms of reimbursement from Medicare, Medicaid, and other payers, juxtaposed against what their salary and benefit package is, means that for the employer of the PA, there is quite a margin, a profit margin, if you will, on that PA service. And even in those situations where Medicare or another payer might pay the PA at a discounted rate, 85%, for example, there is still a substantial contribution margin for that PA to any given practice, whether it's a hospital or an ambulatory care setting. We talk about the right person, right job at the right time, and that's increasingly important as we move toward a fee-for-value concept in healthcare. And what this slide really gets to is the fact that we have to make sure that every healthcare professional working in every setting is working to the top of their license and expertise, because we realize that salaries come out to a certain personnel capacity matter, that doctors are more expensive than PAs who are more expensive than RNs. We have to make sure that when we assign certain tasks, duties, and responsibilities in the healthcare system, that we're making sure we're utilizing folks based on their capacity, competency, and the cost to the system. For example, we would never want to have a PA being used as a scribe. We can see the cost of a scribe is much less than a PA, and in addition to the fact that the PA's personal development would get stunted, it would make no sense in an organization to put a highly qualified, highly paid individual into the role of a scribe, when in fact a scribe is earning less money and can do a great job, but not necessarily needing the capacity and education that a PA might have. So really it's about making sure that we have the right fit, both from clinical competency points of view, but also from the resource allocation point of view. Here's an example of PA value that may help resonate and bring home this point. We're looking at a physician, a general pediatric physician, who was earning a salary of about $226,000. And if you take the average number of hours worked in a given year, for this case we'll use 2,080 hours, we realize that that physician's cost is worth $109 per hour. We take a similar PA in pediatrics who's earning a salary of $94,000, and that equates to an approximate cost of $45 per hour. If we assume a third-party payment of $100, even if the PA is reduced by 15% and the net reimbursement is $85, what we find that at the end of that first visit, because of the physician's higher cost of employment, of expense, that in the first visit of the day with a payment of $100, the physician shows a $9 loss for that first patient visit of the day, whereas the PA, even at the reduced rate of 85%, is showing a $40 profit for that first patient and for every patient thereafter. And the real story here is to make sure that we understand that even when PAs are not being paid at the same rate of physicians, their ability to generate a profit margin or a contribution margin to that practice is still very much intact. What I'm not trying to say here is that somehow PAs generate more revenue in a practice as compared to a physician. That's not true. Physicians typically are the highest reimbursement entities in the organization. But the simple fact is, even at a reduced rate of reimbursement, PAs are highly valuable from a financial point of view within that given practice setting. I also want to point out the fact that it's not just what the PA brings in terms of reimbursement dollars that's important, because while some services are billed out and paid or reimbursed under the PA's name, there are a number of services being provided by the PA in the hospital or ambulatory setting that end up being billed under the physician because of the rules or regulations of certain payers or how services are combined between PAs and physicians. In addition, there are a number of services that PAs provide that are not separately billable. A good example of this might be a global surgical package, in which the surgeon is paid a lump sum of money that includes both the pre, intra, and post-op care. If the PA in that particular situation is providing a lot of the pre and post-op care, there will not be a separate claim submitted nor a separate reimbursement paid. However, that is legitimate medical work that if the PA hadn't done, the physician would have to do. In addition, we understand that PAs oftentimes are involved in the coordination of care, talking with the patient's family, other healthcare professionals. These are services that take up time and require someone with a knowledge of medicine to complete. And it really indicates the fact that a PA can provide many of these services, thereby freeing up the physician to engage in other billable activities. In addition, if you have a PA who's involved in research or teaching or training of other healthcare professionals, again, these are non-revenue producing activities, that do help with the overall management of the practice or the hospital system ended up being valuable concepts and valuable processes that aren't going to be separately paid in terms of reimbursement dollars. I want to give you an example of a hand surgeon that I met when I was doing some hospital consulting. He does a number of hand surgeries, and on Tuesdays and Thursdays is providing those kinds of services. And he had a PA that he had hired about 1.5 years ago. And one of my questions to this hand surgeon was, I realized that for carpal tunnel releases and a lot of the things you do, there isn't going to be a separate payment because Medicare and private payers are not going to pay for first assisted surgery for those relatively minor operations or procedures. And what the hand surgeon told me is that it wasn't a concern about the PA being paid for the first assist. It was really about how the PA made the surgeon more productive and more efficient during those 2 days when he was providing those services. And in this case, the surgeon said that he can provide 2, 3, or sometimes 4 additional surgical cases because the PA is there helping to open and close and set them up for the next case. So even though there wasn't reimbursement dollar being paid for the PA's activities, the surgeon was so much more effective and efficient and generated so much more revenue that it made sense for him, in this case, to hire that PA. In addition, he told me that when they were back in the office doing evaluation and management services, of course, at that point, the PA was fully reimbursed by Medicare and every other payer. We also understand that beyond the reimbursement dollars, PAs do a great job in terms of increasing access to care. We know that in certain specialties, appointment slots are hard to come by. And if someone has to wait 2, 3, 4 weeks to get in to see a dermatologist or another individual healthcare professional, they may not wait that long. They may go to someone else. Having a PA in the practice improves the ability of that practice to get patients in to be seen in a shorter period of time, therefore generating additional patients within that practice. Again, whenever a PA is doing something that is not billable but is required to be done by someone who practices medicine, it tends to set up the physician to see new patients, new consults, new procedures, or what have you, thereby generating additional money for the practice. PAs are also quite good in terms of facilitating communication with patients, the hospital, and other healthcare professionals. So involved in that capacity, the PA can save time and energy from the physician who can be engaged in other kinds of activities. I want to shift and go back a little bit to the global issue because that becomes an important concern in terms of how PAs can be better utilized within the healthcare system. If we take a surgical procedure, and in this case it's a total knee, and if we look at Medicare's guidelines in terms of how it breaks down the fee schedule that is paid for the service, we find that Medicare, in this particular case, allocates 11% of the total fee for pre-op, which is the H&P. 76% of the Medicare payment is for the intraoperative or surgical procedure, and 13% of the total global fee schedule is paid for the post-op care, which is either 10 or 90 days, depending on the severity of the procedure, which means that 24% of a Medicare payment goes for something that doesn't happen in the OR. In this example, I took a total knee, CPT code 27447, payable at $1,700.69. And if we use the Medicare breakdown in terms of the percentage paid, what we'll find is that $194 is allocated for the preoperative H&P, $1,344 is for the work in the OR, the actual surgery, and $229 becomes allocated to the post-op period of time, which in this case becomes 90 days. If in fact the PA were being fully utilized in this surgical practice, what we could find is that if they were going to do both the pre-op H&P and the post-op rounding for this patient, that would actually add to up to about $424. And while that money doesn't come to the PA in terms of a check or a payment, what we can say is that that's the kind of professional work, or that's the amount of money that would be allocated to the individual who did the professional work, in this case the pre-op H&P and the post-op rounding. Now, the claims process is going to show that the entire amount of the global surgical fee, $1,769, was paid in lump sum to the surgeon. But if we were to look at what happens in terms of the actual process of the claim, in this case, $240 would be paid to the PA for the first assisted surgery for that total knee. That's going to be a separately paid amount of money that doesn't take away from the global payment. And what we'd find is that the PA actually earned, if you will, $240 for the first assist, but also their share of the global payment for the work they did in terms of the pre and post-op care, which is another $424. So what we could legitimately say that is that this PA in this case was responsible for $665 of revenue producing work, while in fact it may not look that way on the claim form. Now my issue here is not where the money flows. We think the money ought to flow to the PA's employer, the surgeon, the hospital, the practice. That's not our concern. What I'm trying to point out here is the fact that despite what it might show in terms of the reimbursement dollars on the claim form of the PA generating $240 for the entire amount of work for this particular case, in fact, their professional work product was worth a great deal more. I'd like to take you through some of the regulations and rules regarding Medicare payment. And it's important to point out that Medicare is the big kid on the block. They tend to influence the payment policies of many other payers. However, Medicare regulations are unique to Medicare, and we cannot assume that Medicaid or workers' comp or the vast array of private third-party payers follow Medicare's guidelines. It is extremely important to make sure that you understand the particular payment policy and rules associated with whatever payer you're talking about in terms of private coverage. What we understand is that there are a host of issues that govern what individual healthcare professionals can do within a healthcare setting. Medicare has its conditions of participation. There's the Joint Commission, PA state law, statutes that are outside the PA practice statutes, such as imaging, radiology, behavioral health. There can always be separate different statutes that deal with what PAs can or can't do, as well as Medicaid policy and workers' comp plans. Those are all separate regulatory issues that can impact how a PA can get paid and what they can do. Now, almost every payer in the country will cover services provided by PAs. The key is to determine whether or not those services are paid when billed under the PA's name and provider number, or whether there is a different methodology of accounting for those services, such as asking for the bill to be submitted under the name of the supervising or collaborating physician. Medicare across the board says that services provided by the PAs are covered, and they expect for those services to be billed at the full physician rate. Even though national Medicare policy will reduce the rate paid to the PA if the PA bills under their name and provider number, the claim gets submitted at the full physician rate using the same CPT code that a physician would use for that same service. When Medicare gets the PA's NPI number or PTAN number, that's going to trigger the 85%. It's essential that no hospital or ambulatory practice pre-discount the rate that they charged for Medicare, otherwise there'll be an additional 15% reduction on that. I want to talk in terms of the need of physician involvement. And while it's clear that every PA works with a physician, and that is detailed in state law, and that every PA has immediate access to a physician whenever they're providing care, as a general rule, having the physician co-sign a chart or talk to a patient or review the chart with a PA in the hallway is typically not necessary, at least not for Medicare and for most private payers. And having these things happen will not allow the bill to be submitted under the physician's name at 100%. There are some methods that allow a PA-provided service to be billed under the physician's name, but these kinds of issues, talking to the patient, a quick hello, saying hi in the hallway, are not the kinds of activities that will increase the bill or the ability to be reimbursed at a higher rate. Medicare says that in almost any practice setting that a PA is likely to find themselves, there will be coverage. In fact, what Medicare says across the board is that in any setting whereby a physician would be covered for providing a service, so too will a PA as long as they're acting according to state law. So any department of the hospital, inpatient, outpatient, ED, or the OR, hospital-based office or clinic, any first assisting surgery activities in the OR, an outpatient clinic, dialysis center, or ambulatory surgical center, it's across the board in terms of the practice setting in which a PA will be covered when providing care to Medicare beneficiaries. It is important for every PA to be enrolled in Medicare if they are going to have any contact with Medicare beneficiaries. There are still some folks who tend to believe that if PAs work in a hospital or if they in fact are going to bill their services under a collaborating physician, then therefore they need not be enrolled in Medicare. And that is simply not true. Every PA who touches a patient, number one, needs an NPI number, and secondly, they need to be enrolled in Medicare. The billing aspect comes later, and there are some variations on a theme on that. But again, enrollment and the issuance of an NPI is essential for any PA who's going to provide clinical care to patients. Medicare scope of practice for PAs is fairly broad, and they really defer to state law in many cases. So that means for all evaluation and management services, whether those occur in the office or the hospital setting, are going to be covered when provided by a PA. We sometimes hear that PAs somehow can't provide the highest level E&M code in the office, a 99214 or 215, and that is simply not true. Medicare says that as long as PAs document, as is required by physicians, then they can provide any service that state law allows. The same is true in hospitals. Whether we're talking about an initial patient hospital code of 99221 to 99223 for initial visits, those are going to be covered by the PA when they're provided by the PA and documented on the medical record. Critical care, which is a time-based code, can also be provided by a PA. PAs can provide initial and subsequent hospital care, H&Ps, admission H&Ps, discharge summaries, and they can provide all diagnostic tests and procedures and be reimbursed within the Medicare program. Medicare billing rules for hospitals are almost identical between physician assistants and nurse practitioners. The rules are almost side by side exactly the same. What Medicare will never do is override existing state law. So if a PA is not allowed to do something by state law and Medicare says it's appropriate to do, Medicare will then defer and say that state law takes over. On the other hand, if state law allows the PA to provide a service that Medicare doesn't reimburse or cover, then at that point Medicare takes over and says they won't pay for the service. So there is an interconnection between both Medicare and state law, and neither one can really override the other. But again, it's state law that tends to be the most definitive guideline in terms of what PAs can or can't do, and the same exists for NPs. Now, clearly there are some differences between the two because of different boards that will provide oversight between NPs and PAs. PAs are typically given their oversight by the medical board and NPs by a nursing board. However, when it comes down to Medicare policy, again, most things are fairly similar between those two healthcare professionals. In the hospital setting, there has been some confusion over the past few years about how PAs can be accounted for and how their services should or should not be billed if they're provided in a hospital setting. And part of that confusion, I think, comes from the fact that over the past few years, Medicare has made a shift in terms of its policies. A decade ago, for example, Medicare said that there are two ways to provide care or provide the reimbursement for PA-provided services. It could either be done by using Medicare Part A, which means including the PA's salary in the hospital cost reports, or it could be done by having each PA service billed under Medicare Part B. Well, some years ago, Medicare changed its policies. And now across the board, what Medicare says for physicians, PAs, and NPs is that the only method of getting reimbursed for professional service is through Medicare Part B. It is essential that any hospital that employs PAs or NPs, or physicians for that matter, make sure that none of the salary of those individuals is being included or covered through Medicare Part A through the hospital's cost reports. Everything must be done through Medicare Part B with individual billing for professional services being provided. And it doesn't matter whether a PA is employed by the hospital or working for a private physician or private practice and delivering care in the hospital. Medicare says that they're going to be paid at 85% across the board. Again, no need for the physician to be on site when PAs provide care to a Medicare patient in a hospital. What is a requirement is that there be access to electronic communication, most likely a cell phone, between the collaborating physician and the PA, and that's a requirement of state law. What happens, however, when both the PA and the physician provide care to the same patient on the same day? This is a very common occurrence whereby the PA might be rounding on patients in the morning and the physician will come by either later that afternoon or sometime that same calendar day and provide some level of care to the patient. Well, Medicare's previous rules said that whoever did the majority of the work is the one who had to bill for the service. So in that case, if a PA did 20 minutes with a patient in the morning and the physician came by that afternoon and spent 5 minutes with the patient, Medicare in the past would have said that would be a PA claim, billable under the PA's name and provider number, payable at 85% of the fee schedule. However, in the intervening years, Medicare has changed its policy, and they've developed something called a shared visit policy. A shared visit policy allows for the combination of hospital services that are provided by both a physician and a PA to the same patient on the same calendar day. And if that's done and Medicare's other provisions are met, it allows both services from both individuals to be combined and billed under the physician at 100% of the fee schedule. Now, some of the requirements in place for Medicare are that, number one, the physician provide personally in a face-to-face interaction with the patient some level of E&M service. Medicare typically doesn't get that specific in terms of what the doctor must do in that encounter with the patient. They simply say that it must be face-to-face, and the physician's professional services must be part of the E&M visit and contribute to that entire patient visit. Some of the Medicare carriers talk about the issue of substantive or substantial portion of the care, but again, that's not very well defined. What Medicare wants to see on a medical record or a chart is that the physician provided direct care to the patient, and they want to see it in written format what that physician did for that patient's care. It might be fairly generic, something such as listen to heart and lungs as part of that visit, or talk to the patient about medication management, or talked about the patient's ongoing medical treatment after they leave the hospital. Any of those kinds of activities can be sufficient in terms of physician involvement, but again, it must be clearly identifiable and separated from what the PA has done to make sure that Medicare understands that the physician played a role in that particular service. Talking about shared visits, what we know is that it applies only to evaluation and management services. It does not apply to procedures or to critical care services that are provided in the hospital. By E&M services, we talk about initial and subsequent hospital visits. We talk about admission H&Ps. All of those are included in terms of what is appropriate for a shared visit. Medicare also tells us that the PA and the physician must be employed by the same entity. That means both employed by the same hospital, both members of the same group practice, or a solo physician employing a solo PA could also work. There must be common employment between these two individuals in order for a shared visit to work. If common employment between the PA and the physician does not exist, for example, a case in which the PA is employed by the hospital, but the physician or surgeon is employed by a private outside community group, then there could not be a shared service, and in those cases, each healthcare professional would have to bill separately for their level of service provided to the patient on that given encounter. Again, just to clarify, the documentation must be clear and concise, and we must be able to make a separation between what the PA provided during that visit and what the physician provided. There has to be a clear note detailing the physician's professional service. There must be a clear distinction between what the PA did and what the physician did. And I would always encourage and discourage the use of certain kinds of terms that have been in vogue, especially when it comes to the supervision of residents. And that is the agree with above or read and reviewed. That type of language will never fly with Medicare because it doesn't tell them anything in terms of what service the physician might have provided. It simply means that the doctor looked at somebody else's work and made some interpretation, but it doesn't tell anyone, especially an auditor, what professional service might have been provided by that physician. I'll shift over to credentialing and tell you that the Joint Commission and now CMS have come together in terms of what it takes for the credentialing of PAs, and that requires that PAs be credentialed and privileged through the medical staff process. In the past, guidelines allowed for two different methods for credentialing. One could be through the medical staff process and the other was through the HR equivalent process. But now both Medicare and the Joint Commission are clear that because PAs practice medicine in similar fashion to physicians, they must both be credentialed through the medical staff process. And traditionally, there have been a number of issues that have hindered the ability of hospitals to be comfortable in terms of the billing of services provided by PAs. Part of that's been due to a lack of clarity in terms of the rules and regulations. Sometimes there is confusion over how that relates to resident billing And I will say for the record that there is no connection between PAs and residents in terms of Medicare billing processes. The simple fact is that PAs have a separate defined Medicare benefit, and residents define their ability to bill for services through a precepting physician. Also, in terms of some of the private payers, there have been oftentimes no specific contractual guidelines that govern how the PA should be billed and what kind of payment is going to be made. And this is an opportunity for me to encourage any hospital that is going to hire or has hired PAs to be really clear with your third-party contracts and be specific in terms of PAs being included in those contracts, both in terms of the rate of payment and the responsibility in terms of billing and payment process. There's also been confusion between Medicare Part B and Part A, as I talked about before, and also the issue of what services are going to be provided by the PA but captured by other physicians. I will tell you that the issue of chart cosignature comes up fairly often, and for Medicare's purposes, they generally do not require that there be chart cosignature when a PA provides care, either in an office or a hospital setting. So when a PA does an initial or subsequent hospital visit, there is no requirement that the physician routinely come by and sign the medical record or the chart. It may well be a policy of the hospital in terms of the bylaws or the hospital's desire to have that occur, and that is certainly a separate issue. What I'm telling you is that Medicare does not have that requirement. One of the few times that Medicare does require that work provided by a PA have a cosignature by a physician is when a patient is released by a PA from the hospital, that is a hospital discharge. So whether a patient is discharged from the inpatient setting or the outpatient setting, the ED for example, PAs can do that work, they can bill for the work and be reimbursed by Medicare. However, Medicare does want for a physician to co-sign that medical record at some point after the patient's been discharged. Medicare has not put a specific timeline on when that co-signature has to occur, but for most organizations and most state law purposes, it's typically within 30 days. I will point out that there is a distinction between that issue and critical access hospitals, and that some years ago Medicare changed its policy. And for those patients treated by a PA in the outpatient setting in a critical access hospital, Medicare does not require physician chart cosignature. However, for patients in a critical access hospital who are released from the inpatient setting, Medicare still does require a physician cosignature. Another issue I'd like to talk about is that of hospital admissions, and partly the issue is because that Medicare had made some language changes or alterations in the past couple of years that created a certain level of confusion when it came to this issue. And in fact, Medicare, when it was revising its rules in terms of the 2 midnight rule, decided to what they call clarify some of the existing rules as to who could admit a patient to the hospital. And because the language was awkward and nebulous, it ended up threatening the ability of PAs, NPs, and residents to be utilized in the hospital in terms of the admission H&P. The inpatient prospective payment rules indicated that only a physician could write the admission order, that PAs and NPs could not. And it also said that state law had to be very specific in terms of the allowance of the ability of PAs and NPs to be able to admit. They also required at that point that the physician had to certify the admission, which meant certifying that the H&P had been done, had demonstrated medical necessity, and that the patient had an acuity level that required them to be admitted. There was a great deal of confusion, and Medicare backed off that policy rather quickly when they realized that in many, many hospitals around the country, that is exactly the role that PAs played. So CMS, in short order, issued a 5-page guidance document which restated its position and then clarified the fact that PAs, in fact, are authorized to write the admission order. And the same applies to NPs and residents as well. Now, when PAs write an admission order, it's typically to the service of a physician with whom they work. CMS also clarified the fact that PAs can perform personally the admission H&P, bill for that service, and have it included in the order. They also said that state law did not have to be specific in terms of delegating that responsibility to the PA, and that clarified the problem for most of us. So the bottom line is, at the present time, PAs do have the ability to personally perform the admission H&P, to write the admission order to the physician service, and then to have that service be billed for under the Medicare program. The 2015 Hospital Outpatient Prospective Payment Rule provided additional clarity and also eliminated the CMS requirement for physician certification of an admission. So at the present time, again, a PA can do the admission H&P, can write the order. Medicare does require that that order be co-signed by a collaborating or supervising physician. That applies equally to PAs, NPs, and medical residents. I want to give you a couple of examples here about how PAs are currently being used in rural and underserved communities. Karen Thornton is a PA who works out in rural Montana, and she's been a PA out there for a number of years, and she goes back and forth between a private clinic and the hospital. She typically works a 24-hour shift on Wednesdays where she is the hospital coverage person with no one else being available. On Thursday, for example, she'll see clinics and the patient for 8 hours and then cover the emergency department at the same time because they are in close proximity. Oftentimes, Thornton is the only healthcare provider in that community, and when the PA or physician is away from the critical access hospital, she is running the clinic, the hospital, and the emergency department, and is the only healthcare provider who is there and available to that community's patients. Another example is Jim McCauley, who works for a FQHC in rural Idaho. And in the 5 years that he's been at this particular FQHC, he has been the sole PA and the sole provider at the clinic. And of course, in that capacity, not only does he provide primary care, but has gained necessary experience in emergency medicine, inpatient medicine, hospice care, and geriatric medicine, because when you are the only person in that area providing care to that community, you have to be a jack of all trades and have a wide range of understanding of different types of medicine. Finally, I'll talk to you about Kevin Boland, who is a PA in upstate New York. And he, again, is the only healthcare provider at this clinic, which is now certified as a patient-centered medical home. And Kevin has brought his system up to the point where he received the highest level of recognition from the National Committee for Quality Assurance for having the top level compliance and recognition as a patient-centered medical home, which means the EHR, the meaningful use, and other standards are being met to the highest level. And Kevin is the only healthcare provider in this clinic. He has a collaborating physician about 35 miles away who is available by telephone. So I hope that gives you a little bit of a flavor as to how PAs are being utilized in rural health communities throughout the country, and hopefully some of these ideas can have some resonance and perhaps be some that are applicable in some of the communities in Tennessee. Finally, I want to talk to you about one of the really nice ideas that came about in terms of PA home care. And this is a hospital that decided it needed more care for its patients after they were released from cabbages and other kinds of heart procedures. And this is an issue that is placed in the Journal of Thoracic and Cardiovascular Surgery if you want to look at that particular study. And the hospital decided that they were going to have PAs make home visits to patients post-operatively 2 days after they were released and then 5 days after they were released from the hospital, because this particular hospital was finding that they were getting far too many readmissions from patients, causing their readmit rate to go up, causing penalties to occur to the hospital, but also causing a great deal of turmoil for the patients. So they started this program and found that within the first few months, they had a 41% reduction in terms of the readmitted patients versus the cohort of patients who did not receive these home visits at 2 and 5 days. The PAs provided house calls to 540 patients at a cost of $23,000, but found that it saved in terms of additional care and readmission penalties close to $1 million, which means the hospital is saving $39 for every $1 they spend toward the program, in addition to the patients having a better quality of life. And for this particular study, the most common intervention that the PA provided was for diuretics, hypoglycemics, and antibiotics. So again, another example of how PAs can be used in a rather innovative way to help the patients get better care, to reduce readmissions to the hospital, and to save the healthcare system a great deal of money overall in terms of not having to bring those patients back and provide additional services that could well be covered in a less expensive, less acute care setting. So I will stop here and turn it over to Bill Finnerfrock.
What I'm going to do is talk a little bit about the rural experience with regard to physician assistants, and in particular discuss the Rural Health Clinics program, or what are referred to as federally certified rural health clinics. PAs have been recognized providers under the Rural Health Clinics program since 1977, the inception of the program. And in particular, as a condition of certification as a rural health clinic, all federally certified rural health clinics must employ at least one PA, physician assistant, or nurse practitioner, and have a PA or an NP on site and available to see patients 51% of the time the clinic is open. This was a key component of the program when it was established in 1977 and signed into law by President Carter, and continues to be a key part of the rural health clinic program today. As of the end of 2015, there were 94 federally certified rural health clinics in the state of Tennessee. These are all located as a condition of the program in rural areas, and that would be, for purposes of the rural health clinics program, a rural area is any community of 50,000 or contiguous communities whose combined population should not exceed 50,000. The majority of RHCs in Tennessee are operated as what are called independent rural health clinics. These are RHCs that are typically owned by a physician, could be a nurse practitioner, could be a PA, any entity other than a provider who is legally authorized to own a medical practice in the state of Tennessee. The other designation is a provider base. Those are RHCs that are owned by any entity that are designated under the Medicare statute as a provider, which would be a hospital, a nursing home, or a home health agency. The vast majority, and indeed I'm not aware of any currently, that are owned by skilled nursing facilities or home health agencies. So when we talk about provider-based, we're basically talking about hospital-owned, and those could be traditional hospitals or critical access hospitals. Now, in Tennessee, what we found was that the vast majority of RHCs in Tennessee are owned by physicians and are classified as independent RHCs. This is a very significant difference from what we find in most other states. The trend in most other states is for rural health clinics to be owned by hospitals, and in particular small hospitals or critical access hospitals. Now, I don't know why in Tennessee there's been such little interest in having rural health clinics as part of hospitals or critical access hospitals, particularly relative to other states. But we will explore some of those financials of this as we go through this presentation. We have seen some significant growth in Tennessee with regard to the RHC program, so it's not as though the program is static or has not grown. In 2005, there were 61 rural health clinics. That translates to about 1.1 RHCs per 100,000 population in the state. And today, or in 2015 at the end, there were 94 RHCs, so that's an uptick to about 1.4 RHCs per 100,000 population. And that's not significantly different than most other states. Here you'll see is a map of the rural health clinics as well as other rural health facilities in the state of Tennessee. We'll show critical access hospitals. FQHCs are federally qualified health centers in both urban and non-urbanized areas, a rural health clinic, and then the identification. As you can see, there's a fairly good distribution of those 94 RHCs across the state. There's a little bit higher concentration in the west than perhaps in the eastern end of the state. And if we show the surrounding states, Kentucky, North Carolina, you would see a fairly significant number of RHCs in those adjacent states as well. Under the RHC program, and this is where we start getting into economics, Medicare payments are made on a per-visit basis. Unlike fee-for-service, where it is the payment is actually linked to the service, for rural health clinics, it is an all-inclusive per-visit payment rate. And the payment rate is the same whether a service is provided by a PA or provided by a physician. Earlier, during Michael's presentation, you heard a discussion about how when a PA or nurse practitioner provides a service under the fee-for-service part of Medicare, there's a discount that Medicare will only pay 85% of the allowable, or the payment is based on 85% of the allowable for that service under traditional Part B reimbursement. Under the rural health clinics program, the reimbursement is the same whether the patient was seen by a PA, a physician, or a nurse practitioner. So it creates a significant incentive on the part of the owner of the rural health clinic to have services provided by PAs or nurse practitioners, and taking a look at that. And again, we'll go into some of the economics there as we go a little bit further along. Now, rural health clinics must have, as I said, a PA working in the RHC, or a nurse practitioner could fulfill that requirement. There is no requirement at the federal level for a physician to be on site in a rural health clinic unless there is a state requirement as a condition of either supervision or collaboration agreement with the PA and the physician. So the physician can serve as the medical director, but the supervision that the physician would exercise with regard to the PA is permissible to be done via telephonic communication. There is no requirement that the physician actually be on site or see patients as part of his or her service as the medical director for the rural health clinic. PAs and NPs can practice to the full extent of the law, what is permissible in the state in which they practice, so there are no federal limitations. At one time, there were some minimum federal requirements with regard to physician on-site availability and some specific federal standards with regard to physician interaction, but those were all eliminated a few years ago under a regulatory relief initiative sponsored by the Centers for Medicare and Medicaid to allow PAs working in rural health clinics to work to the full extent. So now the requirement is the physician involvement, the physician supervision, collaboration, chart review, whatever may be there is based upon whatever the state law or state regulatory mechanism is. There is no federal requirement that would either supersede, replace, or in any way impinge on what the state chooses to do with regard to PA practice. We have two types, as I mentioned, of rural health clinics: an independent RHC, typically physician-owned, and a provider-based RHC, which is typically hospital-owned. Within that, we have some differentiations that are important to understand as well. Independent RHCs are subject under the Medicare program to a per-visit cap. So although they get cost-based reimbursement and it's based on an all-inclusive rate, there is a statutory cap that Medicare will not make a payment any higher than that statutory cap. However, if the rural health clinic is owned by a critical access hospital or a small hospital, meaning a hospital with fewer than 50 beds, that cap is waived. If it's a RHC that is owned and operated by a hospital with more than 50 beds, then that cap is in place. So we have independent RHCs, the larger hospital-owned RHCs that are subject to a cap. The smaller RHCs are not subject to a cap. And so what we see here is that for the independent RHCs, the cap is $80.72, and that's the average payment. Most independent and provider-based above 50 beds have a cost per visit that's above the cap, but because they're capped, that's their actual payment. But for those RHCs owned by critical access hospitals and small rural hospitals, that cap is waived. So we see the average payment in a provider-based to a CA, rural health clinic to a CA, is $164.36 a visit, and the average payment to a hospital-owned RHC when it's not a CA but under 50 beds is about $152.75. And again, the provider-based are capped at that $80.72. So there's a strong financial incentive, and this is why I said earlier it's somewhat surprising. What we are seeing elsewhere in the United States is small hospitals, critical access hospitals, either starting rural health clinics or purchasing independent rural health clinics, physicians who are looking to get out from underneath that cap, practices where, as you can see, if your average cost per visit in that independent RHC is $106.22, but you're capped at $80.72, if you go to provider-based under 50 beds or to a CA, you're actually going to get that. So you would see an immediate increase of roughly $26 a visit. And these are the average, and I'll have some specific Tennessee numbers up here in a second. So you can see here the strong incentive to move to that provider-based status, and in particular when you see some of the other things occurring in the Medicare program, these moves to encourage greater integration, vertical integration of facilities, you see why we're seeing such strong incentive on moving our RHCs, particularly those that are staffed primarily with PAs and nurse practitioners, over into this hospital-based category. Now in Tennessee, if you look at the provider-based rural health clinic data, and the most recent cost report data we have for all of the states is 2013. What you see here is the average number of encounters for the physicians working in rural health clinics in Tennessee, provider-based, was 4,772. The average number of encounters provided by PAs working in those provider-based RHCs in Tennessee was 2,688. The cost per encounter for the physician services are $48.21. The cost per encounter for the PA is $38.58. The average physician compensation, total compensation in the provider-based RHCs is $230,000, and the average compensation for those PAs working in those provider-based RHCs is just under $104,000. Now, those numbers are important when we think back to what we talked about earlier in terms of the fact that the Medicare payment to the rural health clinic is going to be the same whether or not the visit was provided by the PA or the physician. So if you're going to get $106 or even $80 a visit, and you have your choice of having the visit provided by a PA who the compensation piece of that total payment is going to be $38.58, or have that visit provided by the physician at $48.21, financially, your incentive is to have as many clinically appropriate visits as you can provided by the PA relative to having that same visit provided by the physician, because it's going to cost you $10 per visit less when the PA sees that patient than if the physician sees that same patient. Again, presuming that it's clinically appropriate for the PA to see that patient. In the independent RHC space, we're seeing an even greater differential here. Now, what you'll see is that the productivity, the PAs are seeing more patients from a productivity standpoint in the independent RHCs in Tennessee. It seems as though the independent RHCs have figured out how to better maximize the value of the PA in that RHC relative to what the hospitals are doing. Now, I don't know why that is, but I think there are some lessons learned. It seems as though there are some lessons to be learned from the independent RHC space in Tennessee for the hospitals who would potentially be interested in starting rural health clinics. The physician visits are down slightly less than what we saw on the previous slide with regard to physicians in provider-based, and the PA visits are up. The PAs are seeing more visits, and what that translates into is an even greater differential, that the cost here per visit is $49.54 for the physician and $32.44 for the PA. Now, if you go down to the last, then what we're seeing is that while the physician compensation is less than what we saw in the provider-based and the independent, there's not a huge difference between what the independent RHCs are paying their PAs compared to what the provider-based RHCs in Tennessee are paying their PAs. But because the PAs are able to see a lot more patients, that 3,300 number of patients on average based on their FTE, the number of encounters, you have a significantly lower average cost per visit for the PAs in those independents. So I think the hospitals may want to take a look at what's going on, what kinds of visits, what types of patients are being seen in these independent RHCs, because if you can replicate those numbers, it could be a very effective way of trying to extend access to care for rural underserved communities for provider-based hospitals, particularly those under 50 beds and those critical access hospitals, to have rural health clinics attached to them. So here we just tried to put it all together. Again, you see the physician productivity is lower, the provider-based to the independent, but the PA productivity is much higher. We see the physician cost per visit is slightly higher at about $1.50, not quite a visit. but that PA cost is about $6 a visit lower. And again, even though we don't see a huge differential, about $104,000 to $107,000 when you average that out over the cost of a year, that's not a huge differential in the PA versus independent provider base. But we do see about a $25,000 difference in what physicians who own their own rural health clinics are being compensated relative to those who are in hospital or in hospital owned. So I think there's some lessons and some data here that folks may want to go back, take a look at, and see if this isn't something that you could do more with in terms of rural health clinics, and particularly your utilization of PAs in these RHCs. Just expanding that out just a little bit more. Again, if you see the independent, the payment per encounter, obviously you have a lot of overhead here that we're not showing on this chart. We could, show that overhead, but those are going to be fairly consistent. Your differential in your overhead isn't going to be any different for the PA or the physician than it would, so that's a wash. Where we're seeing this differential is in this PA physician compensation area and their cost per encounter. So in the case of these provider base where you would have an average reimbursement of $158.55 and your PA compensation per encounter is $38.58, that's a pretty significant differential there that you can do a lot of stuff and provide a lot of care, do some creative things with those RHCs in terms of the kinds of services that you can provide. So I would encourage everyone to kind of take a look at this and see if this doesn't present opportunities. Also, one of the things I would encourage you to look at is earlier this year, CMS announced that effective on January 1, RHCs can be reimbursed $40.82 per chronic care managed eligible beneficiary per month for CCM services. And those services can be provided either directly or under the supervision of a physician, a PA, or a nurse practitioner working in the RHC. This $40.82 is in addition to or separate from the all-inclusive rate reimbursement. You have to meet all of the requisite criteria for CCM, do an initial patient assessment, establish a care plan for that individual. But then after that, you can get this money. You're required to identify 20 minutes of specific time directed at that patient, either by the physician, the PA, or the NP, or someone under his or her direct supervision who is making those services on behalf of the patient. But this is $40.82 for doing this chronic care management. This is a major change in the philosophy of the Medicare program. This is moving towards the value proposition versus the volume proposition I'm sure you've all heard about, where we're now going to start looking at how can we do a better job of managing patients rather than treating them for acute episodic events. Now, this benefit is critically important for hospitals to understand, because the goal here is to keep people out of the emergency room and keep people out of the hospital. So to the extent that we are successful, what that means for the hospital community is fewer beds will be filled with patients with chronic care, fewer patients will be showing up in the ER for problems associated with their chronic care, which means less revenue to the hospital because their patient census would be down, the ER census would be down. Where is that money going to go? The money is going to go into the primary care setting, into the rural health clinic. So if the hospital wants to try and follow that money and say, to the extent that I'm going to lose revenue in my hospitalization due to lower inpatient census, to the extent that I'm going to lose revenue as a result of fewer visits to the ER, but I need to maintain that revenue stream because of the capital infrastructure, the ongoing financial needs to sustain our system, then one of the things you may want to look at is, how do I follow that money? How do I keep that revenue stream coming in? Owning the rural health clinic may be a way to do that. What we've seen in the RHC program is just dramatic growth overall. I mentioned earlier we've seen a 30% increase in RHC growth in Tennessee over the last several years that is not inconsistent with what we're seeing here. And that really began in the 1980s. We began to see a dramatic rise in the number of RHCs. That occurred because Congress approved a number of changes in the RHC program to promote expansion, and most importantly, changes in how hospitals were paid, moving to that DRG system. So we saw a large growth in the RHC program beginning in the late 80s as the DRG system took effect. Hospitals looked to move costs to the outpatient setting, and so we saw that there. We saw a flattening out of growth in the late 90s to a degree, particularly in the hospitals, as we made some changes there with regard to the hospital-based part of the Rural Health Clinic program. It was when they imposed the cap on the larger hospitals. But concurrent with that, we saw the creation of the critical access hospital. And so where we're seeing a lot of growth in the RHC program now is in those RHCs attached to critical access hospitals. And it makes a lot of sense when you think about the fact that the critical access hospital is being reimbursed on a cost basis and the rural health clinic is being reimbursed on a cost basis. There's a lot of synergy there that makes that work. It's also coincided with a number of important changes at the state level in terms of how PAs could be utilized. A relaxation in a number of jurisdictions on the supervision requirements in some states where the physician was required to be on site with the PA. They moved to off-site telephonic communication. That is now the norm across the country. Similarly, we saw an expansion in the PA scope of practice, particularly to include prescriptive authority and the prescriptive authority for controlled substances. And again, that is the norm now, not the exception. So the combination of all of those things really led to the desirability of moving into the RHC space, and all contributed to the significant growth we saw in the number of RHCs over that time period. Throughout the early years, the vast majority were physician-owned. I think even as late as 1988, there were maybe only literally four or five hospital-owned RHCs, but that began to explode. And particularly from 1995 to 2012, we saw that the RHC ownership was about evenly split. But beginning after the adoption of the Affordable Care Act, Medicaid expansion, and other things that were going on in the Medicare program, we've seen this shift from evenly split between hospital and physician-owned to where there's been a decided increase in the number of hospital-owned RHCs. Again, not necessarily in Tennessee, don't know why, but nationally today, the majority, we're seeing about 54%, the highest percentage of RHCs are owned by hospitals. We've seen a decline in the number of physician-owned hospitals. We have about 4% of RHCs nationally are either owned by PAs or nurse practitioners. So that shift is continuing even as we speak. This is really a good model for team-based care. It's something that over the years has often been talked about, but not always achieved. Earlier this year, actually late in 2016, there was a study done out that was published in Health Services Research, and it looked at whether or not the attractiveness of providers to see, in particular, Medicaid patients. One of the things that they found was that rural health clinics, more so than any other provider, urban or rural provider, were much more likely to see a patient who is a Medicaid patient than any other provider category. And they attributed that, one, to the cost-based reimbursement model that eliminated the traditional financial disincentive to see a Medicaid patient, because although I talked about Medicare, there are significant financial incentives for facilities to be RHCs in terms of the Medicaid program. Even with TennCare in Tennessee, many of those incentives continue to exist, and also as a result of the team-based care. Because there's a requirement of RHC certification, they have to have PAs and NPs as part of that team, and that financial differential I talked about earlier, it makes it very attractive. Those Medicaid patients become very attractive in that RHC setting. So what are we seeing as the trends nationally? We have over 4,000 federally certified rural health clinics, and that number is growing. We are seeing increased acquisition by larger systems but still connecting them directly to a critical access hospital. So out on the West, for example, Adventist is a large health system on the West Coast. They individually have, I believe it's now up over 60 rural health clinics that are part of the Adventist system. All of those are attached to critical access hospitals within their system, so they are out from under that cap. So even though they're part of a larger system, they still operate as part of a small rural hospital. The emphasis is on primary care, which is a lot of the emphasis from a national policy perspective. Increasingly, we are seeing regulations removed that impose barriers or unnecessary restrictions on rural health clinics and efforts to encourage new services and expansion. This fits into the future models when you hear about a bundled payment and episodes of care payments. Rural health clinics have been paid on a bundled payment basis since 1977, so they have a lot of experience operating in that. Some of the challenges we're facing, primary care medical homes, ACOs, and managed care organizations have not been as quick to make some of the changes necessary to incorporate rural health clinics into those models. In the case of the primary care medical homes, for example, for many of the early iterations of that, a physician had to be the primary care provider. So because of the PA and NP utilization and reliance in the RHCs, it made it impractical. Those things are changing. We're seeing some things that make the RHCs attractive to more ACOs and to managed care, but those have been a little bit slower to adopt. We're seeing increasing efforts to intrude on the relationship between the patient and the clinician. That's not just for rural health clinics. I think that's across the board. I'm sure you're all seeing that in your hospitals. Outside forces, the payers coming in, the kinds of networks that they are establishing, particularly these skinny networks or narrow networks, et cetera, who's going to be or not part of the network. I will say that rural health clinics, for purposes of the ACO, are designated as essential community providers. So there is an incentive now for many of these plans under the ACA to have rural health clinics as part of their networks. Shifting financial risk from the insurance company, third-party payer, to the provider. I think this, again, is not unique to rural health clinics, does present, I think, particular challenges for rural providers because you don't have the critical mass of patients that make it more feasible to take on financial risk. But as we see financial risk being shifted from the payer to the clinician, to the provider, I think those are going to present some challenges for rural. And then full recognition by PAs, by these private insurers, and then skinny networks. Are PAs part of those networks or not? Some networks I've seen do classify PAs as specialists rather than primary care. This has implications when it comes to beneficiary out-of-pocket expenses, so you want to be sure that your PAs are designated as a primary care provider, not a specialist, in order to remove any financial disincentive on the part of the patient to have his or her care provided by the PA, and decreasing patient face-to-face contact. We're seeing more trying to move into an environment where there perhaps is less face-to-face contact. Whether or not that's good for patients, we don't know, but that's another challenge. And then the economic realities of trying to maintain and sustain a practice. That's why cost-based reimbursement becomes critically important for rural providers, rural health clinics, and the critical access hospitals as well, that ensuring that they have sufficient revenue to cover their costs, that they're not in a DRG or a fee-for-service payment model or even some form of capitation where you don't have sufficient covered lives. The cost-based reimbursement becomes critically important for them. So rural health clinics and PAs, why? Workforce and access shortage. PAs can significantly improve your ability to reach patients that might not otherwise be reachable, particularly those for which there are economic challenges. If you think back to those earlier slides where the PA's cost per encounter is much lower than a physician's cost per encounter, that gives you the ability to put a PA into an environment where the revenue generated may not be as great, but you can make an economically sustainable practice in that environment because your cost per encounter is lower. the various economic drivers in general that are occurring, PAs, are cost effective. So I think that that makes them more attractive, as there is that greater and greater pressure to demonstrate cost effectiveness as part of the payment models. PAs are a good solution. National policy, we're seeing increasing national policies that try to promote PAs and NPs. We're seeing more money being put into PA and NP education, particularly at a time when we're seeing limited growth in the ability to produce physicians. We have significantly increased the ability in this country to turn out high-quality PAs and nurse practitioners from their educational programs, increasing demand. One of the things that the Affordable Care Act did was it made health care more available to folks from a financial perspective. And so we've seen a demand for primary care, particularly from patients who historically were not able to access the system. Increased utilization. We've seen improvements in state laws governing PA and NP utilization around the country, and we're seeing better reimbursement, and that's particularly true for those hospital-owned rural health clinics. Does it make a difference, PA or NP? In terms of the rural health clinics program, it really comes down, in my opinion, to personal preference of the specific candidate for the position. There's certainly ample evidence in the rural health clinics community that PAs and NPs have similarities in their education and similarities in how they are utilized, and in many instances the PAs and the NPs work side by side. Both have been successful in a full range of practice settings. The key is finding the right person for the position, not necessarily the right credential. In most instances, payment and reimbursement policies are neutral when it comes to PAs and nurse practitioners, and that's the way that we have sought to promote it, is that the employer, the individual who is looking to make a decision, should base it upon the clinical skills and ability of the individual who's presented him or herself for that position, not because of some perceived advantage or disadvantage when it comes to reimbursement or other factors that may affect the decision. Look at the individual you're hiring, what particular skills, ability, their philosophy, their approach, the relationship. Base it on that, and you'll be better off than trying to do it, oh, well, we can bake out better for this one or that one based on some perceived reimbursement advantage or disadvantage. Again, outpatient versus inpatient, I think based on my experience and my work over the years, PAs are equally appropriate whether in an outpatient or an inpatient setting. In some institutions, utilization of one or the other may be affected by the line of authority. Does the PA come under the line of authority of the medical director, the chief of medicine for the hospital, versus potentially a nurse practitioner who comes under the line of authority of the chief of nursing? Where do those lines of authority go? How do they cross? That may be something that you want to look at from an institutional standpoint, and how you choose and what type of individual you choose to bring on is what lines of authority have you established within your organization as to whether or not you want to go the PA route or the NP route. Again, they may be affected by the medical hierarchy within your institution, and it's going to vary from facility to facility. Again, choice should be determined by clinical needs and education preparation of the individual seeking the position, not by some perceived payment advantage. Some questions you probably want to ask: what services do you want the individual practitioner to perform? Under whose supervision or direction, collaboration will the individual report? PA educational programs expose students to core specialties: internal medicine, family practice, pediatrics, surgery, emergency medicine, and then elective specialties in various settings in addition to that. NP programs tend to be specialty specific. It'll be a pediatric nurse practitioner program, a geriatric, a women's health, NP, and on down the line. So those are factors you may want to look at, particularly depending upon the type of services and the work that you're having that individual do. And then, Ken, I think you wanted to talk a little bit about the PA education.
Yes, Bill, thank you very much. First of all, let's talk a little bit about how PAs are educated so you have an idea about their educational background. Physician assistants have 6 years of academic preparation. They all have Bachelor of Science degrees, and then they obtain a Master of health science, or a master's degree after they complete the PA program. Most PA programs are 27 months of graduate medical education, which includes both 15 months of didactic work, including 75 hours of pharmacotherapeutics, an average of 400 hours of basic sciences, which include all the things that are in medical school: anatomy and physiology, genetics, medical nutrition, pathology, neuroanatomy, epidemiology, medical research, and a whole host of other topics. And they complete an average of 500 hours of clinical medicine topics, including how to assess an adult patient, a woman patient, a child patient, clinical laboratory medicine, evidence-based medicine, clinical pediatrics, clinical women's health, emergency medicine, geriatrics, and other courses involving both surgery and, again, medical nutrition. Next, they go on to a 12-month clinical phase, which is a generalist-based education similar to what an intern program was for a physician. This includes rotating family medicine, internal medicine, general surgery, general pediatrics, behavioral medicine, women's health, emergency medicine, and an elective. Now let's move on for some questions. First of all, I'll open this up for either Bill or Michael. Question number one is, what are some of the myths that surround the utilization of PAs in hospitals?
Ken, this is Michael Poe, and happy to take that one on. I think one of the biggest myths or misconceptions regarding PA utilization is that PA practice regulations or their payment policies are so different from those of nurse practitioners. In fact, I think that there are many more similarities than there are differences between the two health professional groups. And to piggyback on what Bill said at the end of the RHC talk, there may be differences in terms of the educational approaches of PA programs versus advanced practice nurses programs. There may be differences in terms of which boards govern the practice. But in the clinical setting and for reimbursement purposes, both health professional groups have many similarities. And I think that any distinction that's made on the basis of practice laws or regulations or co-signature requirements or reimbursement rules are not based upon the facts. So I would simply suggest that in gathering information about utilization of PAs, scope of practice, payer coverage policies, etc., that it's important to obtain factual information and avoid hearsay attitudes and information.
Question number two is, thank you, Michael. Can we explain the concept of how the physician PA team works, and especially what supervision means?
Sure. PAs have always had a very close bond and a relationship with physicians, and that continues today. PAs are educated and trained in a very similar fashion to physicians, as you pointed out, and state law requires that PAs have immediate access to their collaborating or supervising physician. However, it's important to understand that PAs practice with a high degree of autonomy in terms of patient care activities and medical decision making. In my opinion, the term supervision is often misunderstood because it may suggest a higher level of physician oversight than is actually a part of the day-to-day practice for PAs. For example, it's very typical for a PA to have their own panel of patients or to be the only healthcare professional in a clinic, especially in a rural community. And PAs have long practiced with that kind of authority and autonomy in terms of their ability to provide patient care. The relationship with a physician doesn't go away, but there isn't that over-the-shoulder oversight or need for a PA to check in with the physician in terms of what to do for the patient.
Michael, you kind of addressed the other question regarding supervision, but the third question is regarding supervision. If I hire a PA in our hospital, will the physician need to be directly responsible or present at all times? Do you want to add anything to that?
Sure. The answer is no. PAs have the ability to deliver services to patients in hospitals, and that means the inpatient, outpatient, or in the ED. And there's generally not a requirement, either by state law or payment policy, for a physician to be on site when a PA delivers care. Now, it is possible that individual hospitals will have rules through their bylaws process, for example, that may be more strict than that. But I would suggest that those need to be looked at because regulatory policy, be it Joint Commission or CMS's conditions of participation, state law, or payer policy does not require that a physician be on site at the same time that a PA is providing care to patients in the hospital.
Question number 4 is, in the outpatient setting, can I have a PA working alone without a physician? I know you've addressed a little bit of that, but you want to add something else to that? Or Bill?
Well, I'll speak at least with regard to the Rural Health Clinics program, and certainly we can have PAs working alone, and we do. It's not unusual, particularly when you get out to the western states, where the physician PA team the physician may be 90 miles away. And I think that's one of the other unique components of the Rural Health Clinics program. As many of your hospital folks will know, in order to be a hospital outpatient department off campus, typically that facility has to be within 35 miles of the parent entity in order to be designated as a provider-based facility. In the Rural Health Clinics program, that distance requirement is waived, and so it's not unusual to have rural health clinics that are very far from the parent hospital and PAs who are practicing significant distance from the supervising physician, but who maintain connection through a telephonic arrangement. So the PA doctor can work together, but they don't have to be in the same facility at the same time.
And question number 5, I'd like to take a little shot at also. What is the difference between using a PA or nurse practitioner either in the outpatient or inpatient setting? As we've all pointed out, physician assistants are trained in a similar way as the physicians, where they're trained as generalists. And as we also mentioned, nurse practitioners usually are trained to focus on a specialty area, whether or not it's in an outpatient or inpatient setting. More nurse practitioners today are geared towards training to be family providers or family practitioners, whereas PAs are trained both to be a generalist, to be able to work and be supervised and work with as a team member, a physician in any practice, especially outpatient center or inpatient center. Michael or Bill, do you want to add anything to that?
No, I think you captured it. I think I get the question sometimes, well, what's better, a PA or a nurse practitioner? And I really don't think that it's a question of what or who is better. As I said during my formal remarks, I really think you have to look at the individual. You have to look at that particular individual's education and training, and then what are the needs? What are the clinical needs for the position you're looking to fill? In many cases, you can fill a position with either a PA or an NP. In other situations, it's going to be one or the other, depending upon, again, what are the individual skills that person brings. But to generalize it to say, well, a nurse practitioner is better or a PA is better, I think you're starting out with a wrong set of assumptions. I think you should look at it and say, who is the most appropriate individual for this particular position? What education, background, skills do they bring to this position, and then make it based on that.
Michael mentioned before the right person for the right job at the right time with the right purpose. It sounds like you're echoing that. Michael, you want to add anything to that?
Well, I think that's right, Ken. And the fact is that any healthcare professional, PA, NP, or whomever, can have the skill sets and the ability to provide care in unique settings. That's a matter of experience and what they want to do in terms of their career path. But what's important, I think, is that the organization or institution who is opening up that position be clear in terms of what it's looking for out of a healthcare professional. That is, that clearly defined role, what kind of specific activities they want the health professional to engage in. So therefore, there's going to be a matching of the culture, the skill sets, the education to match what the organization is looking for. One of the difficult situations is wanting to have someone come in and be kind of a jack of all trades and not have better specificity in terms of the exact role and purpose for that individual to fill that particular position.
And our last question is the role of the PA different in the outpatient or inpatient setting? Michael or Bill, do you want to address that?
Well, I would defer to you as the clinician on that kind of issue, but as I mentioned before, there are clearly different activities as to whether or not that PA is going to be in an ICU unit of a hospital versus doing the floor versus doing post-op care for the patient. And so again, the duties and responsibilities are often different, but they're all within the range and the scope of practice of a PA for that particular job opportunity. So again, identifying what needs to have happen, what kind of culture is in that organization, what kind of onboarding process you're going to put in place, are all the factors that are going to determine the relative level of success in terms of having a PA or another healthcare provider fill a particular position in the institution or in the clinic setting.
I think in the case of a rural health clinic or an outpatient primary care setting, I mean, outpatient and inpatient are sometimes so broad. You have tremendous differentials within those designations, whether it's a hospitalist within an inpatient setting or someone who's working in the OR within that inpatient setting. They're both in an inpatient setting, but the kind of work that they're doing is vastly different. The same thing is true in an outpatient setting and in a rural health clinic. We recently had some significant dialogue with CMS over this point of what are the typical kinds of services provided in a rural health clinic, what a patient might walk in expecting. And CMS was of the view that the vast majority of patients who come into a rural health clinic are seeking just kind of what would be classified as E&M. Patient comes in, you have to do a diagnosis, you use a lot of cognitive skills. But in reality, there are a lot of procedures that are being performed. In a rural community, the ER, the nearest ER or other type of facility may be significant distance away. So you're going to have patients coming into the ER who have an injury that occurred on the farm. They have a laceration. They have a body part that was crushed in a piece of farm equipment. They fell and hit their head and have some kind of a neurological issue that needs to be assessed and evaluated. So the types of people that are going to come into a rural health clinic are not necessarily the same types of patients who are going to show up at a primary care practice in an urban setting, where those individuals with a laceration, some type of a wound, an injury, are going to go to an ER or to an urgent care center, depending upon the severity, are very likely to show up in a rural health clinic. So you're going to have not only the kind of traditional primary care cognitive patients, but you're also going to have those acute patients who need some type of almost mini ER intervention. So you need to, again, look at the particular patient population, what are the demands of the patient population in that community, and then finding the practitioner who best fills that need for that community.
One of the things that I'd like to add is that having been both a clinician and an administrator, PAs are very flexible. In our training, we're trained as generalists, so that it's often interesting in an institution where there's a need to have someone in an outpatient setting or an inpatient setting where you can easily take a PA and substitute them for either or. So again, it's the right person for the right fit, but a PA's education as a generalist allows them to understand how to function and have a specific skill set and competencies which allows them to function either in an outpatient or an inpatient setting. They're used to doing both. With their surgical background, with their behaviorist background, they can function in an emergency room, as Bill was mentioning, in a rural area. But if they went to an urban area, they could easily work also in an academic health center, both inpatient or outpatient, because of their vast skill set and their competencies which they learn in the generalist model. This is very similar to how physicians were trained as internists, where they rotated through a variety of sites before they picked a specialty. So the other key that I think is important is the flexibility of a physician assistant to be utilized either in an outpatient or inpatient setting with both familiarity, an understanding of the culture, and an understanding of how to care for the patients. Would either of you like to agree or discuss that further?
I think you said it quite well. Flexibility is one of the key portions of this profession.
I agree.
Okay, so I want to thank both our panelists today for participating, and I'd like to move on to references and links which we offer our audience for any further exploration in an evidence-based manner. Both these individuals have offered you their emails to further contact them, and we look forward to any questions that might be out there regarding physicians. But thank you both for your work today.
Thanks, Ken.
Thank you, Ken.